Welcome everyone to today's briefing, Ready, Healthy, and Able, addressing health disparities in the military. I'm Beth Battolino, President and CEO of Healthy Women. We are very grateful to you for taking the time to be here today. Our goal with this briefing is to shine a light on the health gaps that are currently existing for service women and service members with female biology, and more importantly, discuss ways in which we can narrow these gaps to best support the health and wellness of our service members. Healthy Women could not be more proud to be the conveners of today's conversation. And I would like to thank Merck, who made this briefing possible. Michelle Sabia, who leads our military initiative here at Healthy Women, will showcase the data in detail in just a moment. Today, we are going to focus on what we found missing in the physical and psychological well-being of service women and service members, leaving many feeling unseen, unhealthy, and unappreciated. This is especially true if they are a person of color or a member of the LGBTQ community. As a leader in women's health, I knew we had to address these issues, and I could not be more proud of the important work that we are doing to support our service women. Thank you again for taking the time to be here today. And now I'd like to turn it over to our moderator, Healthy Women's Director of Education, Louisa Santa Coleman. Louisa?
Thank you, Beth, for the warm welcome and for setting the tone of today's briefing. As a military spouse and public health professional, I'm very thankful my organization is prioritizing the health of service women and service members with female biology. We have an outstanding lineup of presentations. My colleague, Michelle Sabia, will discuss the current state of military healthcare and introduce our new Ready, Healthy, and Able program. Dr. Toni Marengo will discuss her advocacy work for reproductive rights as an OBGYN at the Naval Medical Center in San Diego, and now as a Chief Medical Officer at Planned Parenthood. She will touch on the gaps in resources available to address service women's gynecological and urological needs, as well as abortion access and the potential impact of the Dobbs versus Jackson ruling. Dr. Tiffany Lang, Senior Clinical Director of Utilization Review at Community Behavioral Health, will discuss the mental health implications of gender differences and discrimination in the military and the challenges or barriers to healthcare. She will also touch on the barriers service women face to receiving mental health services. And Jennifer Dane, the Executive Director of Modern Health, will be sharing her personal story with us today, something we are very honored and grateful for. If you have questions during the presentation, I ask that you please use the Q&A icon on your screen. I will be moderating a question and answer session at the conclusion of our presentations. So let's get started with our first presenter, my colleague, Michelle Sabia. Michelle has a passion for health equity and has dedicated her career to supporting underserved populations through education, direct service programming, and advocacy. She is certified in public health and received her master's in public health from George Washington University. She has over a decade of experience in healthcare nonprofits and healthcare delivery settings, managing federal payment programs, community health initiatives, and implementing programs that address social determinants of health. In her current role, she brings her public health expertise and experience as a military spouse to Healthy Women, where she serves as the program manager of our Ready, Healthy, and Able program. Michelle, take it away.
Thank you, Louisa, and thanks everyone for joining us today. As Louisa said, my name is Michelle Sabia. I'm a program manager for Healthy Women. And this work is especially important to me, both as a public health professional and a military spouse. So I'm really grateful to all of you for taking the time to be here with us today. I'm proud to be part of Healthy Women, where we actively look for knowledge and resource gaps that we can work to help fill. And it's that quest that led to us finding the recent findings on the health status of active duty service women and service members with female biology. Over the past 3 years, the RAND Corporation, Government Accountability Office, and Defense Health Board all released reports on the status of active duty service women's health, mission readiness, and retention. And findings among these agencies were all similar and noted that women are 28% more likely to leave the military than their male counterparts for reasons including gender differences and discrimination in access to and quality of healthcare. And that includes things like sexual discrimination, extremely high rates of sexual harassment throughout the military, women not being believed by their providers, their command teams, or their teammates on the symptoms and condition that they're experiencing, which helps worsen the health outcomes that they have. And a lack of provider education and knowledge on the health needs of the female anatomy versus the male anatomy. Servicewomen also noted family planning and reproductive health concerns, aiding in their decision to leave the military. They have difficulty obtaining contraceptives of choice and a lack of understanding by providers of the differences and the benefits of those different contraceptive methods. There are also notes of providers not knowing how to implement certain contraceptive methods, like an IUD or intrauterine device, which limits their already limited options for contraception. Servicewomen also noted concerns about access to pregnancy and postpartum care, as well as access to quality child care services, especially for dual service couples. And servicewomen also report high rates of injury and illness compared to their male counterparts. That includes musculoskeletal injuries, which is often due to ill-fitting uniforms and equipment that are made more for the male body without consideration for the differences in women's structures. There are high rates of urogenital infections like UTIs and vaginitis. In fact, 30% of all deployed women have bacterial vaginosis, a yeast infection, or a UTI. This impacts deployments and mission readiness and can cause medical evacuations, some of which are avoidable or unnecessary, but all of which are very expensive. And of course, mental health issues also aid in the decision for women to leave the military. Digging further into mental health issues on the next slide, women report higher rates of anxiety, depression, and PTSD than their male counterparts. Gender discrimination was cited as one of the most significant contributors to this difference. These service members are already dealing with managing their health conditions in stressful environments, and the addition of not being believed by male command teams and providers, and the stigma that's associated with explaining herself up the chain of command over and over and seeking care contribute to worsening those mental health conditions. In addition, the Defense Health Board noted a few other contributing factors to these differences in health outcomes, such as inconsistent program implementation and lack of accountability, often the result of a lack of funding and leadership buy-in, which causes well-intended programs aimed at reducing these health gaps to ultimately fail. And lastly, and perhaps most significantly, a culture of traditional male norms and attitudes in teammates, leaders, and healthcare providers make it difficult for service women and service members with female biology to get the care that they need. They deserve better. So in response to these findings, we considered these agencies' research, their causes of health gaps, and their recommendations, and we called upon some of our nation's leading military health experts to come together in a consortium and guide us in the development of a solution. And the result of that consortium was the creation of a comprehensive educational program called Ready, Healthy, and Able. This two-pronged approach, our program is a two-pronged approach to addressing health gaps for service women and service members with female biology, with our initial focus being on reproductive health, urological health, and mental health, three areas those agencies all noted as of utmost importance. To educate our service women and service members with female biology, we're providing evidence-based educational content, including infographics, fast facts, and real stories of fellow service women who are navigating their health journeys. The goal is to increase education and knowledge of symptoms and health conditions that may affect them, and to reduce the stigma and empower them to seek the help that they need and advocate for themselves within the complex military health system. The second prong of our program is aimed at healthcare providers. Our intent is to offer an accredited educational module to military healthcare providers of all levels, not just to doctors, so that we can help close the knowledge gaps that exist so that they are prepared to meet the health needs of service women and service members with female biology. This will be offered virtually, on demand, and in person so we can accommodate all busy military schedules. We're really excited about the potential for this program to address the existing health gaps in service women and service members with female biology. I encourage you all to review our resources and use them as you're advancing legislation to support this population. And you'll be hearing next from 3 of our consortium members who will dive further into these health topics. Thank you again for your time today.
Thank you, Michelle. And before we move on to the next presentation, I just wanted to remind everyone, if you have any questions, please add them in the Q&A icon and not the chat. Thank you. Okay, so now I would like to introduce Dr. Tony Marengo. Dr. Tony Marengo is a specialist in women's healthcare, the Chief Medical Officer of Planned Parenthood of the Pacific Southwest, and on the Executive Council for District 4 for the American College of OBGYNs. She earned her undergraduate degree from Stanford University, her medical degree from Northwestern University, and completed her residency training at the University of Colorado Health Sciences Center. After residency, she served in the United States Navy as a staff OBGYN and was honorably discharged as a lieutenant commander in 2007. She was also the director of family planning at the Naval Medical Center San Diego, the only physician in the military system to hold that title and position. In her current role of CMO of Planned Parenthood of the Pacific Southwest, she leads clinical services for 18 health centers across a 3-county region in Southern California. She provides direct clinical care, advocates for the sexual and reproductive rights of all people, and teaches residents and students. She's also a member and co-facilitator of the Ready, Healthy, and Able Consortium, and we are so pleased to have her with us. Go ahead, Dr. Marengo.
Thank you so much, Louisa, for that kind introduction. And we can go ahead and go on to the next slide, if that's okay. You heard my bio, and I just wanted to give you a little bit more information about me and my why. This work is so deeply personal to me. As you can see, I hope I don't look too different. I grew up in a military family. My father retired. He's a Vietnam era veteran, retired out of Camp Pendleton here in Southern California. So I grew up as a recipient of the military healthcare. Later went on to the United States Navy as a staff OBGYN and was able to proudly provide healthcare for thousands of active duty Marines, sailors, and their dependents. After my active duty time in 29 Palms, I went into academic medicine at the University of California, Irvine, but was soon called back to duty in a different sort of capacity as a civilian OBGYN working for Naval Medical Center San Diego, the largest OBGYN training program in the Navy. So for many years, trained residents, and ultimately, my practice as a comprehensive OBGYN really started to gravitate more specifically towards sexual and reproductive health care. As I saw, this was just a large gap in our military healthcare system, and I believe that really helped me move to the position I am in today as the Chief Medical Officer at Planned Parenthood of the Pacific Southwest. It was a difficult decision to leave my military family after serving for more than a decade, but I really believed that it was time to take a step and have a larger voice for advocacy in this work. I remain in this region in particular so that I can continue to care for people with uteruses who are active duty and veterans in my own community, as well as our broader community here in Southern California. And as Louisa mentioned, I'm just so proud to be one of the subject matter experts and co-facilitators for the Healthy Women, Ready, Healthy, Able program, because I really truly believe that we can solve most things through education. Next slide, please. So Michelle already this morning introduced several resources and reports, and I'm going to focus just a little bit more on the Defense Health Board report that came out in 2020. It summarized specific findings and presented recommendations to improve the health and readiness of active duty women. It outlined goals to improve accessibility and quality of health services and optimize medical readiness. The report is 190 pages and includes a high-level summary of 14 findings. The main healthcare issues discussed were musculoskeletal injuries, mental health, military culture, deployments, violence against people with uteruses in the military, nutrition, eating disorders, and of course, reproductive and urogenital health, which I will touch on over the next few minutes. In particular, the report spoke about specific needs around gynecology, urologic needs, contraception, and a small portion of it mentioned abortion, but I certainly wanted to touch on that today, especially in light of the recent decision, Dobbs decision that happened in June. Regarding gynecologic needs in particular, the report highlighted issues such as pelvic pain, menstrual regulation, abnormal uterine bleeding, access to assisted reproductive technology, which would include things like in vitro fertilization, egg freezing, etc. Urologic needs would include things like recurrent urinary tract infections and painful bladder syndrome. I know Michelle touched on this, but one of the main issues that came up was a lack of healthcare providers who are truly knowledgeable in these areas, as many people with uteruses in the military are deployed in places and don't have access to specialists who understand their biology and the issues that I mentioned already. An interesting point about contraception, when I was active duty myself in the military, I was really surprised by the lack of availability and understanding around contraception. It is a key part of obstetrics and gynecologic care. Family planning is quintessential as people with uteruses move through their lives. And an amazing thing about military healthcare is, there was no copay. So I thought, well, at the time, providing healthcare, this is going to be great. It's going to be so easy to help reduce unintended pregnancy and provide people with family planning needs because we've reduced that barrier. But where one barrier might be reduced, other barriers are put up, unfortunately. And I strongly believe that's around education. So I will speak about this in a few more slides, but through my time in the military, I came to understand that accessibility really had to do with education. And my goal was to provide a simple platform to deliver contraception. The Defense Health Board report specifically calls out walk-in contraception clinics as the best practice in the military, and we'll talk about that. I think something to highlight and kind of how I like to lead conversations is with the bottom line up front. And my bottom line up front here is that things like the Defense Health Board report and several of the best practices highlighted in that report bring to light that there's so many things already available in the military. Things have been researched and time and again lifted up, but not acted upon. And I really enjoy and support working with Healthy Women because this group is acting upon the report that is put forward and really trying to solve some of the issues that are highlighted. And finally, like I mentioned, we'll talk about the post-jobs decision in the landscape in the military. Next slide, please. I think it's important just to remember that women in the military face hurdles to reproductive health that many civilians don't. And I think until you serve or you are actively providing, it's really hard to understand all of those reasons. So I definitely recommend reading kind of the highlights of the Defense Health Report to understand what it is like to serve in a predominantly male-oriented community with fewer resources dedicated to you when you're trying to serve the mission. Next slide, please. Chapter 6 of the Defense Health Board report really focuses on reproductive and urogenital healthcare services for active duty women and really describe kind of the life cycle of the active duty woman. So early in an active duty woman's career, things like access to contraceptive services, access to hygienic products and practices, especially while they're in the field and deployed, are lacking. As well as health, riskier sexual behaviors can lead to increased risk of sexually transmitted infections. So providing education, support, and appropriate treatment for all of those issues is tremendously important and needs to be timely, certainly. As a woman or a person with a uterus in the military continues throughout her military career, other issues in her life cycle come up, such as ongoing family planning, pregnancy-related issues, fertility issues, and then childcare, as Michelle mentioned. Women in the military face pregnancy discrimination. I can't tell you the number of times people were coming to me for healthcare and saying that they didn't want anyone to know they were pregnant. They didn't want to be put on their fit rep. They really wanted to deploy. I will say that time and again, women with uteruses in the military are stigmatized, and it's believed that they're just getting pregnant to avoid things like deployment. I can say now in the civilian sector on the other end, in the practice that I'm in, I have many pregnant people coming to me seeking abortion so that they can serve in the military. I've had pilots want to get back in the sky. I have had, soldiers and sailors say, my ship is leaving for deployment and I need to be on it. And they want to be back on the mission and in the fight. And they don't want to tell anyone about their pregnancy because they don't want to be discriminated against or passed over for promotion. Gender discrimination, which I'm sure my colleague, Dr. Lang, will talk a little bit more about, as well as some of the urologic and hygiene issues I talked about. I will just, one story about gender discrimination I'll tell you is, I serve today with someone at Planned Parenthood who works on my security team, and she was deployed in Afghanistan and unfortunately had a traumatic brain injury during that time. And she remembers after the IED went off that she got up and, looked at her crew, and she was the only female on the squad. And, the guys were looking at her and they're like, oh, are you out? And she's like, no, I'm fine. I'm okay. And she knew something was wrong, but didn't want to say anything because she didn't want to feel like she was lesser because she didn't want to be discriminated against because of her genetic sex. As, cerebral spinal fluid is dripping out of her ear, she continued in the fight. And I'll say that I hear those stories time and again from active duty women. Next slide, please. So how do active duty women stay in the fight? One of the issues that has come up is that active duty women have higher rates of unintended pregnancies, and this is proven in the literature, and it's what I saw every day working for the military, and it was one of the reasons that I became a co-founder of the Walk-In Contraception Clinic, because it's not just about family planning for the patient, right? It's an important thing, and we want people to have autonomy, but for the greater military mission, we understand when we join the military that we wear the uniform of our country and we are there for a specific purpose. And manpower is an important issue. And when women who make up 18% of the military are unable to deploy or need to be removed from a ship because of a pregnancy complication or taken out of the field, this leaves the rest of our forces undermanned and causes significant issues. So that is how we continue to move ahead with contraception and promoting the Walk-In Contraception Clinic. There are several reasons highlighted here why there are higher rates of unintended pregnancy in the military. I'll let you read through those. But access really should not be an issue. We should be able to have access to contraception, as I mentioned, because of no copays and because we have military health care that should be accessible and easy to get to from all bases. Next slide, please. So I've mentioned a couple of times the Walk-In Contraception Clinic. My partner and I at that time called it Operation Pink, Process Improvement for Non-Delayed Contraception. It was the first clinic of its kind in the entire military. And I remember at the time approaching my department head and saying, I would really love to create a clinic kind of like a Planned Parenthood, so a little bit of foreshadowing, where people with uteruses could just walk in and get whatever birth control they qualify for on the same day without waiting periods. I found when I was active duty that many of my patients would have to request a visit from me. They would have to get a counseling visit first. Sometimes this would be delayed by 30 days, sometimes 60 days. By that time, the patient might be pregnant or might already be deployed. So we came up with this simple walk-in contraception clinic idea, created a walk-in contraception clinic in a box with some easy check-in paperwork. And this really became a best practice. Before I left the military as a civilian associate program director and director of family planning at Naval Medical Center, San Diego, I was sitting on a BUMED working group that promoted this program. And at one time we had over 25 walk-in contraception clinics in country and out of country. And I spent several years actually talking about how to implement these clinics on military bases, primarily within the Navy, and then the practice began to spread to other branches. Next slide, please. Unfortunately, due to COVID, military cutbacks, many of these clinics have closed. The Defense Health Board report specifically does call out that this is a best practice for military medicine and has mandated actually that DHS make this type of clinic, this walk-in contraception clinic, available at all military treatment facilities by January 2023. And while I'll say that's fantastic to put on paper, Really, the implementation is going to take manpower and finances. And my own former hospital, the founding hospital of this clinic, currently, you will see from the list, does not have a walk-in contraception clinic. And unfortunately, due to billet cuts, particularly in the OBGYN department, they're unable to staff it. And I do hope they'll be able to meet the mandate by January. But I do have listed here the 18 locations where the military is currently offering walk-in contraception clinics, which, by the way, has been proven to save the military several $1 million due to manpower and staffing, as well as taking care of unintended pregnancy. Next slide, please. As I mentioned, there are already many tools available within the military, but they're not always widespread because people don't know about them. So one of the things I'll highlight is the Decide and Be Ready mobile app. That is also best practice. And then most recently, TRICARE has waived co-payments and cost shares for medical contraceptive care, which also sounds fantastic on paper, but unfortunately there are still things like needing authorizations. So if a large military treatment facility like Naval Medical Center San Diego is unable to care for people with a walk-in contraception clinic, it would be wise for them to send those patients, what we call out in town, to civilian providers. But because TRICARE has several issues with authorizations and allowing IUDs to be placed by a location like a Planned Parenthood, there are still ongoing barriers. My hope is through Healthy Women and the Ready Healthy Able program, we'll continue to promote the need for contraception, the tools to provide contraception, hopefully at military treatment facilities, and if not there, inspire military providers and patients to continue to advocate for themselves so that they can obtain the healthcare that they need. Next slide, please. Finally, I don't think any talk about reproductive and sexual health care in the military would be complete without at least touching on and mentioning what has happened since the Dobbs decision. I think it's important to point out that there's already been testimony in front of Congress. There's been many Q&As written. The Secretary of Defense has spoken on this. And the quote that I pulled was, while the department will continue to be able to provide to service members the same level of health care it has always provided, the Dobbs decision will change available options for some service women, some service members. And all I can say is, I think that's a tremendous understatement. I served in the military, as you know, and what I tell people often is that I was already working in a pre-Roe v. Wade world because of the lack of access to abortion and the stigma against people in the military who become pregnant. When you say that we're giving you the same level of health care the military has always provided, unfortunately, it is an underserved population, and it's already was difficult to obtain abortion services if you needed an abortion, regardless of the reason. Because that reason is deeply personal and should be between a patient or a healthcare provider. But now in 26 states, it's nearly impossible, or there are even more barriers. And there are many military bases in very restrictive states that are going to make it that much more difficult for our service members to access abortion care. And while there are many things being talked about as far as transporting patients and allowing them to get the care they need, remember, we're still going to have to overcome stigma and the Hyde Amendment. Next slide, please. So why is the military in that situation? I also would not be able to complete this talk without mentioning the Hyde Amendment. Henry Hyde was quoted to say that he would certainly like to prevent, if he could legally, anybody having an abortion, a rich woman, a middle-class woman, a poor woman. Unfortunately, the only vehicle available was the Medicaid bill. And through that bill, what many people don't realize is that in addition to patients who are recipients of Medicaid, anyone who has federal health insurance, including military members, those on Native American reservations, those in federal prisons, immigrants, all of those are affected by the Hyde Amendment. Next slide, please. So in summary, I hope I've outlined some of the needs that are there for women or people with uteruses in the military, and highlighted some of the things from the 2020 Defense Health Board report on active duty women's healthcare services. And remember that the DoD was asked to look at quality of care, access to health services, address psychological and mental health conditions, and reproductive health services. All of those issues in orange are in the first year of what Healthy Women and the Ready, Healthy, Able program is looking to achieve through education, as Michelle already mentioned. Musculoskeletal injury prevention is also on our radar, hopefully for year 2 as this program progresses. And Healthy Women has been working diligently with the consortium to answer these major findings in the Defense Health Board report. I'm really looking forward to promoting our webinars, as well as leading some of our in-person trainings at military bases across the country in 2023. And we're so happy and proud to be here to present our program to you. And thank you for allowing me to speak this morning.
Thank you so much, Dr. Marengo, for all the very valuable information and resources you always provide to us. I'd now like to welcome Dr. Tiffany Ling. Dr. Tiffany Ling is a licensed clinical psychologist and has served in senior leadership roles in government, nonprofit, and private organizations. Dr. Ling earned a doctoral degree from Spalding University in Louisville, Kentucky, and completed a postdoctoral fellowship in women's health. She has over a decade's worth of experience working with underserved or marginalized communities and has devoted her professional career to promoting health equity and expanding access to inclusive health services. Her areas of expertise and passion are in trauma reactions, substance use, military veteran populations, LGBTQ+ affirmative care, and advocacy. Currently, she is the Senior Clinical Director of Utilization Review at Community Behavioral Health in the city of Philadelphia, where she oversees the growth and standardization of person-centered care management, programming across categories of behavioral health services to vulnerable populations who are Medicaid eligible. Dr. Ling is also a member of our Healthy Women, Ready, Healthy, and Able consortium, and we greatly appreciate her guidance over the past few months. Welcome, Dr. Ling.
Thank you, Louisa. As mentioned, with a career focused on military veteran populations, it is a personal and professional honor to be here today to overview some of the mental health considerations for women service members. Compared to 2 decades ago, the number of men in active duty service has decreased by 5.6%, while the numbers for women have increased almost 15%. Depending upon the branch, women are 9 to 20% of our all-volunteer active duty military. These numbers may be surprising for some, yet women represent the fastest growing population of military service. Unfortunately, women's mental health has not received enough attention to keep up with the numbers and demand. This has resulted in several gender-specific gaps in care and increasing rates of mental health symptoms among women service members. Women's contributions to the military can be dated back to the Revolutionary War, yet there continues to be the issue of invisibility for women service members, both within the military environment and healthcare system. Within the military, this often looks like an overemphasis on gender when it's not relevant. Women finding themselves having to outperform their male counterparts for the same advancement opportunities, and the assumption that gender impacts one's ability to fulfill duties. Within healthcare, invisibility contributes to overlooking early signs of mental health concerns, minimizing symptoms when they're reported, and stigma about seeking mental health treatment. I'll speak more to the impact that this invisibility can have on women's mental health, but I think Major Mary Hager said it best. Instead of seeing my strengths and how I could contribute, he only saw my gender. Military service involves situations and experiences that are outside the realm of routine possible for most civilians, such as separation from family, relocation, and deployments. Having a strong social support system, or the camaraderie that the military provides, is one of the greatest protective factors against mental health symptoms and suicide. Unfortunately, many women service members experience gender isolation and find it difficult to be integrated in the male-dominated environment. One study showed that about 1/3 of women service members experienced gender bias and had trouble receiving recognition as a military professional. These obstacles can impact women's decision to stay in the military, which reduces the number of women who advance into more senior ranks and therefore reduces the number of women role models for professional development. Women also experience unique stressors within the military. Some of these stressors range from dealing with equipment not designed for female body, gender discrimination, heightened risk of interpersonal violence, military sexual trauma, reproductive concerns, as well as bias against mothers. Many of these stressors are intensified with deployment, which often leads to additional childcare concerns and emotional pain due to separation from children. In our society, parenting pressures are largely placed on women, and this is often amplified within the military culture. Stressors, especially gender discrimination and sexual harassment, are known to have a negative impact on mental health. Mental health stigma is also heightened within the military, where it's common to view mental health symptoms as a sign of weakness, and treatment is often avoided due to concerns about the impact on one's military position, such as security clearance. This stigma is intensified for women service members who often find themselves having to challenge assumptions and prove their worth. As a result, many are hesitant to report any stressors or symptoms for worry that it'll just reinforce the stereotypes about women in the military. Dr. Marengo just highlighted and shared a number of situations and examples in which this occurs. Given the unique stressors that a male-dominated military culture can have on women service members, it's not surprising that the research shows that women in the military are more likely to experience mental health symptoms when compared to their male counterparts. The impact of these gender-specific stressors is obvious when we consider that mental health concerns are higher among women service members for nearly all diagnoses, including adjustment disorders, eating disorders, trauma reactions, depression, postpartum symptoms, as well as a heightened risk for suicide. While a thorough review of the research is beyond what can be covered during our time today, this slide overviews some of the findings on how much more likely women are to experience mental health symptoms when compared to their male counterparts. As previously mentioned, the unique stressors and lack of gender-specific healthcare are often a factor in why these numbers are so high for women in the military. And when we look at the rate of suicide, it is unacceptable for women in the military to be 3 times more likely to die by suicide, with those rates even higher during deployment. While there has been improvement to women's mental health in the military over the previous decades, the advancements have not kept up with the need. Women continue to be underrepresented in research and program development, which has impacted the availability of quality training for military healthcare providers. And if providers are unaware of the unique stressors and care needs for women service members, then mental health concerns will continue to be overlooked or minimized. Competent gender-specific healthcare involves much more than good intentions. There is a degree of specialty skills required to identify mental health concerns early and provide quality treatment. Women have long proven that they're capable of valuable military service, and now it's our responsibility to ensure they receive quality care. It's time to close these mental health care gaps and overcome the barriers to accessing gender-specific healthcare within the military. The Ready, Healthy, and Able program aims to address these barriers through development of research-informed quality provider training to keep women fit for duty in an environment that recognizes and celebrates their contributions to military service.
Thank you, Dr. Lang. Very, very important information as well. Last, I'd like to introduce Jennifer Dane. I'm now pleased to introduce the CEO of Modern Military. Jennifer is a veteran of the United States Air Force who served as an intelligence analyst focusing on geopolitical, terrorism, and threat vulnerability issues. She has earned a diversity and inclusion certificate from Cornell University, an associate degree in intelligence studies from the Community College of the Air Force, a Bachelor of Science in Criminal Justice from Bethel University, and a Master of Arts in Criminal Justice from Arizona State University, and a Master's of Art in Education Policy from The Ohio State University. Jennifer is also a past fellow of the Mission Continues Service Leadership Corps and Veterans in Global Leadership. Welcome, Jennifer.
Well, thank you so much. And thanks for allowing me to be here to speak with everyone. My name is, like you said, my name is Jennifer Dane. I'm an Air Force veteran. I served from the years 2010 to 16. One thing that really resonated with me whenever Dr. Lang spoke was all these issues The one thing that we didn't talk about, or we haven't talked about, that needs to be explored is the intersectionality of not only our women's identity, but for me specifically, it was my woman identity and also my sexual orientation. So I'll get into that a little bit more, but my military career started off with obstacles. During basic training, I was in a all women's flight of female trainees. And I had a female drill instructor, and it was laden with maltraining. We had a denial of food that was given to us. We had psychological trauma. We had one girl in my flight attempt suicide. She has survived, thankfully. And even medical care was denied, especially when females needed to go for reproductive purposes or contraception. Even though we were simply in basic training, there was no need for anything else. For sexually active folks, I mean, contraceptive care was very needed then. So we were denied that at the very beginning. And it was by a female drill instructor as well. Years later, I would testify at her trial, where she would receive 9 months of military incarceration in a military prison. But like myself and many other countless recruits were survivors or victims of the malpunishment that she provided. And that was simply just during basic training. That was the start of my military career, especially as a first generation military member. I didn't know any different. And it was sometimes, kind of set the career of what to do or what not to do. But talking about the intersectionality that I mentioned in the first, I served in the years 2010, and it was at the cusp end of the policy called Don't Ask, Don't Tell. For those that weren't familiar with that, Don't Ask, Don't Tell was put into place in 1993 by President Bill Clinton as a means to not ask someone their sexual orientation and not be able to tell. It was a policy that was a compromise to make sure that you could openly serve, or that you could serve in the military, but rest assured that you wouldn't have to have your sexual orientation disclosed. But for me, the unintended consequences were dire. So in 2010, I was and am a survivor of military sexual trauma. During that time, so not only was my basic training pretty rough, I went to my tech school for my career training as an intel analyst, and one of my fellow service members sexually assaulted me in the barracks, or in the dorms in the Air Force. That's what we call them. And I was a virgin, and I didn't know who to tell. And the only thing I knew was that if I expected my troops to report it later on in my career, that I should do that. And so I did. But because I was serving under Don't Ask, Don't Tell, I couldn't tell them that I was a lesbian. And because of that, I couldn't share really the truth about what happened that night. I shared all that I could, but I couldn't share that. But the defense attorneys did come back and openly ask me in 2010 if I was gay. So what that meant for me is this policy that was created in 1993. The unintended consequences of it was that an investigation was started into me because I reported a crime. And also, is I couldn't share the truth of what happened. So the service member ended up being able to finish his career and do it again, which is not uncommon. I wanted to share that I know many, many female veterans, and although the statistics are 1 in 3 are survivors of sexual violence, there is not one that I know that hasn't been a survivor of military sexual trauma. Not saying that they don't exist, but it is a huge problem. And some of the things that were said earlier about people not believing you. Whenever I reported my incident, no one believed me. They thought that I was making it up. I was stripped of my military leadership role. I was put on the same duty as him. And the consequences of that were really a lot of pressure on my mental health. And because I was in a career that had a security clearance, it was very difficult to want to go to mental health and get help. So I turned to alcohol, and I turned to other things that were not productive because I couldn't really share the true self of who I was. And then you look at the health disparities for women in the military who maybe not want to have children, but also that do want to have children, specifically in the LGBTQ community. Access to reproductive health is in both active duty and also the veteran side is very scarce. There has been movement to provide more care, especially on the veteran side, but there's still roadblocks, like being married in a heterosexual marriage is one of the requirements for receiving reproductive care, or it was. It's being changed at the moment. So everything adds on, and then the intersectionality. So I am able to have the privilege of being a white woman, but if I wasn't, the disparities that come with, being a person of color, or the gender identity that's different, or sexual orientation that is different, it exponentially adds on to the pressures of what we're seeing. And there's not much competent care that goes into this. Whenever I was seeing a doctor on military installations, I was really fearful of disclosing my sexual orientation because I was afraid that I would be outed and that I wouldn't get the care that everyone else did. So we weren't asking for anything else besides the care that everyone else had. It's not a special privilege. It's just being able to receive the care. And there's many things that have occurred that occurred in active duty that translate into, into the life of a veteran afterwards. So whenever I got out of the military, I didn't want anything to do with the military. And I went to receive, VA healthcare. And there's still barriers there about feeling safe and secure. And I know this is about service women, but we have to think of the lifestyle, the life cycle of a service member. And those increased rates of suicidality. I myself, during the pandemic, attempted suicide. Didn't have any signs that showed that would be a thing, but I was unsuccessful in that attempt, thank goodness. But there are so many things that even you have to reach out to this population. You have to make sure that they feel welcomed and affirming, and that these barriers are lifted. And that's with education and making sure that we believe them, making sure that we're doing everything we need for them, because it's really important for not only like our national security, which is a huge issue, and if we can retain these women. I know for the Air Force, 30% of women make up the Air Force. So we were highly represented, but we still face these same barriers. For our population specifically, the LGBTQ, there has never been any data that's been collected. There's actually been a ban on data collection for sexual orientation and gender identity until this year. So more robust data collection would be highly, highly sought out after, specifically for ethical means and through the use of optional self-identification of sexual orientation and gender identity. Because there are so many people serving in this country that fall into these intersections of being a woman and XYZ. And there are so many barriers that exist that can be fixed, and they should be fixed. Women's service is significant, not only with just healthcare, mental health care, but for national security as a whole. So that's kind of my experience as a servicewoman. I would say that it had some great advantages, but also some very low lows during my service. And there was so much room for growth. And there has been improvements over the course of time, like victim advocates being able to be present. Don't Ask, Don't Tell was repealed. And I was able to serve my service successfully. And it also comes with the privilege of being, a passing white woman in the military in a career field that was highly sought after. So there are so many factors that overlay into this experience that also have to be considered. So more ethical research needs to be developed for that. And for me, I'm only in this role because of the unintended consequences of a policy. So when you are making policy, make sure you ask the questions. ask what implications could this have, what unintended consequences, or what intended consequences, because there are so many that need to be explored and need to be ethically considered. Even if you're doing across the aisle politics, make sure you explore all those consequences, because even 2010 was not too long ago, but it still is a present thing that I have to face every day, is the effects of my military service. So I really want to say thank you for Healthy Women for letting me be here, and the other panelists, and I'll leave some room for the other questions that other folks have.
Thank you so much, Jennifer, for your vulnerability and for sharing your powerful story that I'm sure will inspire others as it has inspired me. We will now be taking questions from the audience. So I encourage all of you and any of you to add some to our Q&A. I know, Dr. Marengo, you've answered one of them, so thank you. Let's go ahead and move to one of the questions that we have for Dr. Ling. Do you think educating men on the health needs of women could help break down gender discrimination and gender isolation?
So absolutely. Dr. Marengo spoke about kind of the importance in education and raising awareness of a number of issues. And yet education is oftentimes a place to start. We also need to invite men into the solution about what they can do with this education and this information to create kind of the cultural changes that we're dialoguing that actually need to be put in place for women service members to get the most out of their physical and mental health care.
Thank you, Dr. Lang. This question is for Jennifer. The majority of those attending this briefing today are staff representatives from the Hill. Are there any particular legislative efforts you know of that would help address some of the issues we've laid out today?
I'm not sure about the legislation. I mean, for me, especially for the LGBTQ community, this week, as you all know, the Respect for Marriage Act is being introduced on the floor. So for me and my community, specifically, not just women, but everyone in the LGBTQ community, that's one legislative piece that would really help. And also passing the Equality Act. I know it's not on the floor, but specifically for servicewomen and veterans, I know that, Representative Julie Brownlee does a great job. Representative Spear also, I know she's retiring, has done a great job with women, with women service members and veterans. And then Jill Brand always does a really good job with helping, especially for military sexual trauma. I'm not sure of any bill specifically, but I know that there's great movements in both the House and the Senate to make sure that, regardless of who you are, military members and veterans are fully taken care of. And there's a great women's veteran task force too. I know this is servicewomen, but if you're looking at the veteran side, I know that Representative Brownlee, I believe, leads the women's veteran task force, and her staffer is wonderful and is on this call. So it's a really good place to start, but looking forward to seeing more movement. And I know there has been great movement, especially as the passage of the Deborah Sampson Act that I believe happened last congressional session. It was a great stepping stone to what we need for women veterans after they leave the service.
Thank you, Jennifer. We have another question in the Q&A. The VA has maternal care coordinators, which have now been codified. Does the military have something similar? If so, how can the program be improved to ensure military service members who are pregnant get appropriate perinatal care so they can continue to serve? Dr. Marengo or anybody, do you know any information on this?
Certainly on the active duty side, when service members become pregnant, we have full scope OBGYN, obstetric services, social work. I'm not certain if they're called specifically maternal care coordinators. I think it's not as much about the care of the woman once she becomes pregnant. I think, unfortunately, the stigma of pregnancy itself, and specifically what we were talking about today for patients who wish to avoid pregnancy, how they're able to do that. And then for patients who become pregnant, who don't want to be pregnant, how are they not forced into ongoing pregnancy? I do believe when a service member becomes pregnant, she gets high quality health care. It's just a matter of, how soon she reports it and if she wants to continue. I think after the service member delivers, I think there are other issues as far as parenting, remaining on active duty, and childcare issues that come about. But for the actual time of pregnancy and delivery, I believe we have robust services.
Thank you, Dr. Marengo. This question is both for you, Dr. Marengo, and Dr. Lang. 1 in 5 mothers experience maternal mental health conditions in the civilian population. What is being done to ensure servicewomen are identified and treated during pregnancy and postpartum?
Well, I can briefly just talk about during pregnancy and the postpartum period that military healthcare providers are trained to address depression as far as screening. And I find this in the civilian sector as well. We are not mental health professionals. We will screen for depression. We will do our best to identify if patients are at risk during pregnancy, at specific times during their pregnancy, as well as the postpartum period where pregnant people and immediately postpartum people are at increased risk for depression. But I do find that services at that point are difficult. There's a lack of mental health providers in the military system and in the civilian sector, which, once we've screened, and then I turn to Dr. Lang and say, now what do we do? And I think that's a major issue. So I think the screening is there, but the actual treatment is quite lacking due to manpower and expertise.
Yeah, Dr. Lang, do you want to add anything?
Yeah, so I think it's also in regards to how we approach the discussion as well. There's not a lot known about perinatal and postpartum conditions, whether it's depression or anxiety or even obsessive compulsive conditions. So having that conversation for women during that time frame can be extremely difficult due to the stigma around it. Like, what are the typical kind of baby blues versus what are some of the things that I need to address or identify and request for mental health treatment? There's also a number of reports that show that when women are disclosing this and dialoguing about some of these symptoms, that they do tend to be kind of overlooked as kind of normal kind of pregnancy or early motherhood conditions as well. So in terms of not only just screening, but also kind of informing providers about what are those symptoms and what are those stressors that would benefit from a referral to mental health treatment so that women can be proactive in addressing this while they're also navigating kind of the early stressors of pregnancy and motherhood.
Thank you, Dr. Lang. We are getting
If I
close.
could add one thing.
Yep, go ahead, Michelle.
I just want to add both for this question and the previous question, I think it's important to note that not all care across all military facilities is the same either. And so while we might have really robust services on one base or one hospital, that doesn't mean it's the same across the board. So there are huge discrepancies in the type of care and type of services and how robust those services are at each base, each hospital, each medical facility, each clinic. And I think that's a really important thing to note as well.
Thank you, Michelle. Really important. Before we close out, I'd like to go around and hear from each of our presenters, just a couple seconds on what is one takeaway you would like our audience to get out of today's briefing. So let's start with Michelle.
Sure. I think it's important that we give servicewomen and service members with female biology a safe platform to share their journeys and to inform your legislative actions. I think we need to ensure that the voices that we're hearing from are representative of the armed forces in race and ethnicity, in sexual orientation, rank, socioeconomic status, to get a really full picture of what that servicewoman's journey is. And then actively support programs aimed at supporting servicewomen and service members with female biology, with funding, with leadership, and with legislation so that we can really make moves and closing these health gaps that exist.
Thank you, Michelle. What about you, Dr. Marengo?
I would just say that, time and again, the military is brought together and even other groups have brought together consortiums of experts and have provided really robust information about the issues and brought to the surface, scientific response and education. And and it's unfortunately not been acted upon. I don't know how many times throughout my career while I was in the military and out, I heard things about how we're going to end military sexual trauma. And, listening to Jennifer, we know that hasn't ended, right? I was active duty not long after Tailhook, and there was this huge response to that. And I guess being here today, I just want to say it really is time to act. We have the tools, we have the knowledge, we have the ability. We need to continue to work with our community partners, but we need the funding and we need the manpower to promote these programs and to provide the education to actually make a difference. And it's very disheartening to continue to read reports about what should be done and then to not act upon them. So I hope that we're not faced with ongoing decision paralysis when we know how to solve some of these problems. And I'm really looking forward to taking ongoing care of active duty service members. And it's been my great joy and the goal of my lifetime. So I'm so proud to be here.
Thank you, Dr. Marengo. What about you, Dr. Lang?
Just simplistically, change starts with a conversation. The more that we recognize that women make up about 1/5 of our military, the more we recognize their valuable service, the more we're able to contribute to the dialogue about what needs to be done in order to prioritize their physical and mental well-being. And while we can all be a part of that conversation, I think the audience and you all play a role in being able to assist in how that conversation gets changed into legislation. And we can all play a role in figuring out how we close those education gaps within the military. Thank
you, Dr. Lang. What about you, Jennifer?
Yeah, so I think that, this issue is definitely a bipartisan issue. It's not one side or the other. And I think understanding that is truly important, regardless of whose office you sit in. And similar to Dr. Lang, I mean, really going in and having those conversations and asking folks, and actually doing something. Like I said a second ago, by Dr. Marengo, we've had all these conversations about preventing sexual violence, but yet the numbers still go up for various reasons, but it's still an issue. So how can we solve that? And I think that reach out to organizations that are doing the work. And I know most military serving organizations are led by men. So that really tells you there's a lot more work needed to be done in this space, and just ask those questions, connect with folks, especially from underrepresented groups that have not historically been asked those questions. So thank you.
That concludes our briefing for today. I want to thank our presenters. You all did an amazing job of highlighting the gaps while also offering solutions to best support our servicewomen and service members with female biology. I will also love to thank our audience for attending, and thank you again to Merck for making today's briefing possible. Healthy Women invites you to please visit our Ready, Healthy, and Able site at military.healthywomen.org. We're here to work with you to support the health of servicewomen and service members with female biology. We want to be your partner and resource for women's health, so please reach out to us as you're working on legislative efforts for this population. Again, thank you all for joining us this morning, and have a great rest of your day. Bye, everyone.